Hello, and thank you for joining the Wisconsin Parkinson's Association's educational video series. I'm Jeremy Otte, Director of Outreach and Education with Wisconsin Parkinson's Association. WPA provides hope, community, support, and resources for people with Parkinson's disease and their loved ones. Today we are talking with Dacy Reimer, a board-certified nurse practitioner who specializes in Parkinson's disease and movement disorders. Dacy is with the Neuroscience Group in NENA, and she's going to discuss on and off times in Parkinson's disease and treatment options to help you manage them. Welcome, Dacy. Thanks for joining us today.
Thank you for having me, Jeremy. I appreciate you inviting me.
Not a problem. Well, many people probably know you, but you want to give us a little bit of a background about yourself and the Neuroscience Group?
Sure, yeah. I am a nurse practitioner, like you said. I specialize in movement disorders. I have specialized for, well, going on probably 25 years, I think, by now. So all I've done my whole career is care for people with Parkinson's disease. The Neuroscience Group is a program in NENA. They service the Fox City area and also northern Wisconsin. It's a group of about 40 providers, meaning neurologists, neurosurgeons, nurse practitioners, and physician's assistants. My office is in NENA at their primary location there, but they have 9 other centers and facilities that they also treat at, including Berlin, Fond du Lac, De Pere, Marinette, Shawano, Green Bay, Sturgeon Bay, Wapaka. So they're quite extensive in the northern Wisconsin area.
Excellent. And do you want to touch on, for those who are seeing this new, you have not always been with the Neuroscience Group. When are you starting with them, and how can they maybe contact you if they want to set up appointments going forward?
Sure, yeah. So I'm new to the Neuroscience Group. I start there on June 29th, and I'm very excited to join them. They're located in NENA. Like I said, the address is 1305 West American Drive. The phone number there is 920-725-9373.
Perfect. Thank you for providing that.
Mm-hmm.
So in the introduction, before we jump into talking about on and off times, I mentioned you're a certified nurse practitioner. What does that mean for people who don't know what a nurse practitioner is versus a physician or even a physician assistant, as you mentioned?
Sure. Yeah, a nurse practitioner is a nurse who has either a master's degree or a PhD. We then get certified in treatment of people in generalized medicine. And although I've specialized obviously in neurology and specialized even more than that in movement disorders. So I can do what a physician can do. I can diagnose, I can treat with medications and prescribe medications. I can order labs, I can order diagnostics such as MRIs or CT scans and that type of thing. So we're really comprehensive in what we can do, and we can manage the whole person and all of their care.
I appreciate that. I think I get a lot of questions from people that don't fully understand what a nurse practitioner is, and I think you've given a very good overview, so I appreciate it. So we're talking about Parkinson's disease. Can you describe, maybe clinically or to a person, what on versus off times really mean in Parkinson's disease?
Sure. Yeah, a lot of people who are viewing this might not have any idea what we're talking about, because not everybody with Parkinson's has what we call off periods in Parkinson's. And when we describe something as being off, we're really talking about a reemergence of their symptoms, their Parkinson's symptoms, when they've been treated. So the whole goal is that we can get those symptoms at bay. So that really kind of varies. Not everybody, like I said, has it. You can have that reemergence after you've initiated therapy at varying times throughout the course. I guess the important thing to kind of start out with before we really dive too much into off time is really discussing, or at least that's what I cover with my patients, especially in a new patient visit, is what are your symptoms? what is it that you're experiencing to begin with? We know that Parkinson's is a loss of dopamine, and dopamine's a neurotransmitter in your brain that can control a lot of different things, movement, but some of these things are not just movement. So it may be that you had tremor. That was your initial symptom with Parkinson's disease. It may be that you were slow or stiff or scuffing your feet or having a hard time getting out of chairs, or had balance problems. So it's really important to first really know what your symptoms are and identify them, because it's not uncommon for people to come in and go, well, I have arthritis too, and I have back problems and all of these things. And how do you know what's Parkinson's and what's not? So really it's a matter of doing that initial education with your patient and saying, this is part of your Parkinson's, this is not, that's a separate entity. And being really clear so that they can identify what truly are Parkinson's symptoms and keep track of that, because otherwise you can't talk about these off times, because you don't know what the symptoms are that you're treating. You'd actually be a little surprised how many times I think people don't have that education with first visits. I have people who have come into me and they've had Parkinson's for 7 to 10 years. And I say, well, let's go back to when you first started medication. What happened? What improved? And they go, well, I don't know what was supposed to improve. Okay, so we got to go back to ground zero here and start educating on what those symptoms are in that specific person, to be able to really have them have an awareness of them, so that we know when we treat what we're improving. When I do treat with a medication, I write down what I expect to improve. So if a person has tremor, then that might be part of it. But they might have more slowness in their legs than tremor. So it might be that our main focus is that slowness because it affects their balance, and maybe not so much tremor. Maybe the tremor doesn't get in their way. So we really have to individualize it to each person and set our priorities, not just my priority, but the patient's priority and what they want to improve. And I usually tell them my goal is 70% improvement or more. And I make them kind of keep track as we're going along and starting a medication on what improved and how much. And I do that because otherwise they'll report to me, yeah, I'm a little better. Well, a little bit, maybe 4% or 40%. And I need to know how robust that response is to be able to know where to go on the dose. And so that's kind of the start of where, of this discussion, because it's hard to get to talk about off times if you don't initially know your symptoms, you don't know how much better you got them to begin with. So the whole...
Let's touch on that for a second, Dacy, because you talked about, really recognizing the symptoms. I mean, you said you've been specializing in Parkinson's for 25 years, I believe you said. I'm sure you found people will walk in and everything they have is because of their Parkinson's disease.
Right.
My arthritis is bad because of my Parkinson's disease. So I think, as you said, figuring out what is Parkinson's and what isn't is very important. But I think the other thing you said that's really important, and I want you maybe to touch on a little bit before we do go into off time, somebody comes in and they're focusing on their tremors really bad. And you're like, well, that slowness in your leg is a bigger concern than the tremor. So how often do you talk to a patient that you go, okay, you're more worried about the visual symptom, but here are the symptoms I'm worried about, and here's why I'm worried about them, that maybe they undervalue to some extent?
Absolutely. And that happened yesterday. I had a new patient, really. He was an old patient that I had seen at the Regional Parkinson Center when I was there. And he had Parkinson's since the 80s. I mean, he's had it a really long time. And his reason that he came to me was because he was having more tremor. And I asked him, does it interfere with your eating? And he said, no. And I said, well, does it interfere with you buttoning your buttons and getting dressed and, your activities of daily living? And he said, no. And I said, okay, when I did his exam, he was very slow in the legs. He could barely pick up his feet to, to move them and do the foot stomping that we do when we do the testing. And I said, well, I'll be honest, my concern is more of that. And I know I can really gain some improvement in that with treatment and improve the balance. And he's actually right now at a rehab facility. So, he's there to try to get back home again because he needs this as intensive therapy. Well, if you're working with therapy and you have body resistance, how able are you going to be to achieve that goal? You're working against your body, So I said to him, it's really prudent that right now we work on trying to improve that leg movement because that's going to help you reach your goal of getting home, and that your wife is not going to have to help you up so much and help you with your movement, and that it'll keep you more independent. And he had been that way for so long, that kind of underdosed, that it was the new norm. It was really the new norm. And I think you have to make people aware of the fact that what you can improve. What can I get better with medications? And what can't I get better with medications? The tremor can be a little tricky at times because it can still be there. It's really about how much it gets in your way of doing things in a day. So there are times that we're kind of talking apples to oranges, and it's really important that we're on the same track, because otherwise he's going to come in when I've made a medication change. He'll go, nope, the tremor's still just as bad. And I'm like, well, I wasn't treating the, So, and the other thing is we're not treating me. It's not my body. So it's really important for me to know that his priority has to be my priority too, but he has to know what I can get better. So that's more common than you think that we have to have that discussion.
I appreciate you really digging into that. I think that is a huge, whether you're newly diagnosed or had it for 30, 40 years,
Mm-hmm.
A lot of times we can't see the bigger picture and we're worried about maybe the visual.
Mm-hmm.
I think that's a great discussion and probably jumps us off now into talking a little bit about off times.
Sure.
So I interrupted you, so I'll let you go back to touching on that a little bit.
No, thank you. So off times, when we say off, is really a reemergence of symptoms. So with some people, it's that they feel like when they take their medication, it wears off prior to the next dose. And they can kind of time it. They know, well, 30 minutes to an hour before the next dose, they slow down a bit, or they have a harder time getting out of chairs, or the tremor reemerges more. So it really just depends on what those symptoms were that you initially had and how much they reemerge. For other people, it could be maybe in the morning when you first wake up. Maybe you took your last dose of medication, Parkinson's medication, before you went to bed, and that was at 9 o'clock at night. And now it's 7 o'clock in the morning, and you're pretty low on dopamine and pretty slow. And so it takes taking that dose and having it kick in, so to speak, in order for you to really kind of get moving. So for some people, that's pretty dramatic, and for other people, it's really subtle. So you have to ask the questions to the patient. So, and that's the real key, is that it's not something that people come in and report often. It's something I have to, as a provider, dig around for in our conversation and identify as early as possible, because there are things that I can do with the treatment protocol to alter that, to fix it fairly quickly, I feel. And I think it's really important to do that before we get really high, peaks and troughs in their control. So, those are the things that we're looking at for conversation, is me asking, well, how do you feel when you first wake up in the morning? Can you move well? Or do you feel like you're slow? Well, now some people might say, well, I'm kind of stiff. And I'll say, well, is that in the joints or in the muscle? Because we're sometimes talking about arthritis too, or arthritic pain in the joints and things. And with Parkinson's, it's more of a stiffness in the muscles than a pain in the joint. So you have to dig around at the conversation and really identify, is this Parkinson's or not? And is this part of the course for this person? And then throughout the rest of the day, do you have periods of time that you feel you are more mobile than others? Is there a certain time of day that's just always seems to be a bad time of day? And what happens to your body during that time?
You mentioned, I mean, the importance, A, of asking the questions and really talking to, I'm going to assume, having known you as long as I have, it's the patient and the care partner that you're having those conversations with, because the care partner may see things that the patient doesn't want to talk about. But you said, it's important to have that conversation so we can address the treatment protocol. Do you want to touch a little bit on what you mean by treatment protocol? Because I know so many people, myself included, when I used to use the word treatment, I just went, oh, medication. But I know you're meaning way more than just that when you say treatment. So can you maybe expound on what that means?
Absolutely. So of course it can be treatment, meaning medications. With Parkinson's, we're trying to replace dopamine. And there are many medications for dopamine replacement. But you're right, it's not just about medications. I always say to people, and this is our initial visit in our conversation, is this is a team here. We're a team, and I don't have any magic beans that will make you better. It definitely takes exercise and a willingness to get better and be regimented on an exercise program as well. When we're talking about medications, the gold standard medication for Parkinson's is carbidopa-levodopa. That medication has been around since the 60s. And it comes in an immediate release formulation and an extended release formulation, and also kind of a super extended release formulation in Rytary. Since that time, all the clinical trials that have been done on medications for Parkinson's disease, the goal of that has been to make them longer acting so that we can prevent off periods, because we know that can happen with shorter acting medications. And I just wanted to hit on too that when we're talking about like how often does that happen, that people feel the medication wear off? Well, there are a lot of different kind of surveys and studies on that, and it really just depends on the facility. But about 18% of people report in the first 5 years of treatment the beginning of off periods. 56% report it within the 6 to 10 year mark. And then we're talking like 74.5% from 11 to like 15 years. So it kind of varies. And I don't want to put a stamp on that because it really does vary. I've had people come in that are newly treated and they seem really sensitized and they can feel on and off symptoms. And I need to know that and be careful with those people, or maybe change the regimen a little earlier to a longer acting medication. And others I've known for many years, and they've never had off periods. So it really does vary. And that's why it's important to have that discussion and really dig into the person's daily activities to know how functional they are to be able to derive on a medication regimen. So like I said, the carbidopa-levodopa is our gold standard medication. Since then, more medications came out. There's a category called dopamine agonists. That includes Requip or Ropinirole, Mirapex, also called Pramipexole, Nupro or Retigotine, which is a patch that you put on. It's a transdermal patch, so it's not an oral medication. It's absorbed through the skin, so it avoids the gut. There are so many medications. There are what we call COMT inhibitors, including Comtan. And to a lot of the people, these can get confusing, on the names of the medications. There's a whole class of medications that are called MAOB inhibitors. You might know those as Azilect, or Rasagiline, Xadago, Selegiline, and the goal with those medications are kind of to bolster the effect of carbidopa, levodopa by about 10-15%. So that whole group. Every medication has a side effect profile, and that's part of the selection when we're talking about treating Parkinson's. And it's about looking at a person's health history and also looking and knowing what symptoms that you're trying to alleviate. And so if a person has tremor, there are certain drugs that are tremor specific. If there's a person who's on a certain medication, you might want to avoid one of the other medications so that there's no interaction. So it really is important to have that discussion about the type of medication. But the whole idea, if a person is starting to experience an off time, is to change gears on the medication regimen and add in something that's longer acting to smooth out the control. In the studies, in the clinical trials, which I was very fortunate to be involved in for many years, and most of the medications that are on the market, we know because we take blood levels periodically throughout the study. So I know exactly when that peaks and troughs in the body. Well, you can't see that. You can't see that, but the person reports it, and it's very interesting how easy it is to correlate that trough. That trough in the blood level is the same as what the person's reporting as an off time. That's when you have that potential for those symptoms to reemerge during that low period. So all these new drugs are meant to keep a steady blood level of the drug so that you don't have, an off period. But no matter what, you do have some peaks and troughs. But it's important for the provider to be able to identify that that's a trough with a reemergence. And what our goal is to try to get that up so that it's even keel and you're productive your whole day, or as much as the day you can be. There are some people that have off times that are very predictable. They can tell me, yep, at that noon dose, for some reason that noon dose, it's always, it wears off and my tremor reemerges about a half hour before then. Well, I need to know that. And does it happen with just that dose, or does it happen with every single dose? Sometimes it's a matter of adjusting timing of the dose of the medication. Maybe you don't have to add more medication or change it. Maybe I just have to change the timing on when that person takes it. That's simple. Well, kinda. Sometimes it's not that simple. If you've got it down pat, it's not always that simple. In fact, yesterday I had a fellow too who had just started therapy, and he's like, I just can't remember that afternoon dose. I'm out working in my yard and I really have a problem remembering that dose. And I said, well, so by the time you remember to take it, is it your body telling you that you need to take it, or are you remembering to take it? And when people are first diagnosed, it's usually just remembering to take it. But after a while, if you were to miss a dose, your body would probably tell you because you'd slow down.
I'm going to interrupt because you had a couple really good points I want to maybe touch on. I think it was really interesting when you talked about the clinical studies, how when you did the blood, you could really see kind of when that trough was happening. And then I got to think from a clinician standpoint, that's really reassuring for the patient that it's not just in my head that I'm having an off time. I can actually show you with the blood level where the dip is going to happen, so they know it is really happening. It's not just their head thinking it's happening. So I think that's huge. And then I think the other thing you said that I want people to really hear, once in a while it may just be the timing, not more medication. I think a lot of people are always hesitant to tell the clinician, hey, I'm having off times because I don't want to take more medicine. And I think you made a great point going, well, we may just move the timing one way or another, and that may be the only thing we need to do. Not always, but it may be that simple. I think that's a really important point that you touched on, and I think people really need to hear as well.
So, you had mentioned, just about the fact that, people can have, other people can observe those off times as well. That can be hard for a person to explain to family. And if they don't understand that, why were you mobile? Why could you do this before, but now you can't? And it is real, it is legit. And a lot of times that's part of the the discussion I'm having with caregivers or family, or even with a facility, is saying, yes, this person can fluctuate in how much they can do, and you need to know they're not faking, that this is real. But I'm going to try to fix it, of course, as best I can, but it is real. And the person experiencing that can get very frustrated as well, as they just feel like the people around them don't understand. And so that really is important. And yeah, the easy move on the chessboard is timing. I mean, as long as the person can remember to make that adjustment. I am very conservative with medicine. I don't believe in just adding more and adding more. And I think people worry about coming into the office and reporting problems, like you said, because they are worried about getting more medication. Now, on the flip side of that, I also say to them, the winner at the end of this race of life, is not the person on the least amount of medication. It's the person who is the most functional and the person who stayed the most independent. And so it really is about working together and saying, can we take the same total daily dose and convert it into something that's longer acting? You're not getting more medicine, but can we smooth out the control throughout the day? And what are our options with this gamut of medications that we have to do that? And so it doesn't always mean more medication. It just means maybe there's a switch. Maybe they need a longer acting that's an equivalent dose, or maybe we need to spread it out. Maybe you're taking it 3 times a day, and we could take that same equivalent dose and spread it out to 4 times a day, and just really kind of fill in those gaps. So there's options, and it's really important to have the conversation about it, because it's going to make you more functional and better.
And I think as you talk about being more functional, being better, whether it means more medications, timings, it's quality of life. I think it's something, it's that buzzword we hear in the health field, but it is trying to give you the best quality of life possible, no matter what you have as a diagnosis. I think that's really what you're hitting on. And I think that should be encouraging to anybody when they're looking at long-term prognosis. So you've touched a little bit on some of the medications that are out there for treating Parkinson's as well as off time. You kind of touched on not everybody has off times, not everybody recognizes it. So can you maybe touch on, you talked a little bit about identifying the symptoms, but what would you tell somebody if they are feeling some of those off times? What are the things they should be looking for, and what are the things they should be telling their clinician when they get in to address it sooner rather than later?
Yeah, that's a good question. And again, it's individualized. I had another lady yesterday who, when she sleeps at night, she notices that she has more cramping in her muscles. Okay, so we call that a dystonia, or it feels like a Charlie horse. To me, as a clinician, I know that she's having a trough. So her blood level of the medication is coming down during the night, and that's probably what's triggering that Charlie horse. The last time she was in to see me, she had said that it only happened, maybe once every 2 weeks. Well, that's not a trend, and so we don't always necessarily make a medication change based on that. But I said if it happens more often, you need to report it, even if it's in between visits, and it might mean that we need to make an adjustment, in the dosing. And so, and those are the things I'm keeping track of and hitting on with every visit. So like I said, the key point is making sure that you're identifying early when somebody might be starting to have these peaks and troughs, and that you're with somebody that can identify that. And because otherwise it'll go unscathed, for a long time before it's identified. And one of the things that can happen is that you can have what's called dyskinesia. So you can have a peak as well. And what we know with these medications is the higher the high, the lower the low. So if you have a really high peak, you can have a really low trough. So it's really important to level that out. I had one fellow that had come to me he sees me regularly from Michigan, and he came in, and as he was talking to me, he had some just kind of little subtle swaying movements, to his torso. And one of my questions I always ask is Do you have any involuntary movements or any swaying movements throughout the day? And he said, no, but I can see them. And his wife kind of looked at me like, yeah, that happens. And so I needed to know that, because if I let that ride too long without trying to, again, give him medications that level him off more, he's also going to have valleys. He's also going to have low times as well. So it takes knowledge on what those peaks and troughs look like, and educating the patient that that's what it is, because that wasn't bothering him, but I know at that point that I should probably change gears on medication regimen. And I always say to my patients, because I need to keep you looking good for a long time. And that really is my goal. It's especially if it's a young onset. And young onset patients are more prone to having off times because they're on medication longer. Their course, their time of being on medications is potentially longer than somebody who was started at age 65. So if you started with Parkinson's symptoms at age 40 and you were treated early, it's quite likely, like I said, 11 to 15 years out, 74.5% can have off periods. I need to know that going in. I need to be smart about what medications I even start with to keep them looking good for a long time.
Excellent. One of the things I want to go back to, and you've said a couple times, you talk about, as a clinician, you track symptoms, which we assume medical records, you're doing that. But you also tell the patient to track the symptoms. They should be keeping, tuned with certain things. How do you have them do that? Are they keeping a diary? Are they putting it in their smartphone? How do you recommend they're keeping that track so that they can come in and, I laugh and you said the woman said, well, every 2 weeks. Well, I know from experience when somebody says, well, I fall once or twice a week, that means probably 4 or 5 times a week.
Right.
So how are you making sure they track that and making sure the data is accurate?
Part of that is probably a lot of caregiver involvement as well, because it can easily be underreported. And again, that depends on the person. Some people, I have people that give me charts, you know what I mean? And they're very, they're very good at documenting things. I don't want people to spend their whole life, every minute focusing on Parkinson's either. The whole idea is that you're out doing something, that you're out living your life and not overly focusing on Parkinson's symptoms. However, it's a matter of having that discussion and that awareness of going, oh, that's Parkinson's. I need to either jot that down. Patient diaries are great. Having some place that you kind of go and write things down. I don't want you to write everything you do during the day in that diary. I just want to be able to kind of, even if it's just on a calendar, and you're going by and you had that symptom that day or that low period or that a certain time of day that was an off period, just jot it down. Then go do something, because you can definitely over fixate on Parkinson's, and I don't want that as well. But so sometimes I actually have diaries that I print off and give people that are a day, a week, and it depends on how elaborate you need to be with that person for documenting if they are able to do a diary. Otherwise, it's a matter of marking it on the calendar, or even on a notepad. So I really just try to work with the person individually on how they do things. Some people use their smartphones, and they can kind of put it in there. But I definitely have people that make me graphs, so I don't need that much information. It is helpful, but honestly, I dig around in the conversation for that information. That's not, it should be every single visit that stuff is brought up. And you might not know what I'm talking about if, and I say that, well, do you ever have periods where you feel like you're, slow, or you have a harder time getting out of a chair or anything like that? And they don't know why I'm asking that, or cramping in your muscles that feel like a Charlie horse. Nope, good. Good to go. So I do more digging around than anything, only because I don't want them to overfixate.
Well, I appreciate that. I think you said it well. It's not good to overfixate. I think the part that I'm most excited that I heard you say, it involves caregiver involvement, talking to the care partner and really finding out what they're also seeing, because I think In support groups and other discussions we have, the care partner often kind of says, well, what is my role in the doctor's appointment? I think you've just touched on their role is to be present and provide feedback or input when necessary or appropriate to help with the quality of life of the individual they're caring for. Well, I think you've touched on a lot, Dacy. I really appreciate it. I think you've touched on symptoms, treatments, how to really pay attention to certain things. Is there anything from a clinician standpoint that I haven't asked you yet that you're like, Jeremy, I can't believe you didn't ask me this, and we should really talk about this quick before we wrap up?
That's a good question, because I probably could talk about 2 hours on this subject. So, I mean, there's just so much information. I think that the key kind of wrap up when I'm talking about this is if you have Parkinson's and you're thinking about your initial symptoms of Parkinson's, it's important to know exactly what they are. Again, I write them down for people, and those are our goals that we're trying to achieve. Is it easier to get out of a chair? Is it easier to get on and off the toilet? When you're walking your walk for 2 blocks, does your right foot no longer kind of scuff or hit that lip in the sidewalk to make you more potential for falls? So I'm really very specific on what I'm looking for. From a patient standpoint, if you exercise, that is the best way to be able to report your symptoms and how well you're doing, or if there's any decline, because you know how long you can ride a bike or walk on a treadmill, and if that's changing. If you have a regular exercise regimen, you know if you're going to know if you're getting better on a medication, because you're going to be able to do more, you're going to be able to achieve more, you're going to reach higher goals. You also will know if there's a decline, because it'll be a regular thing that you're going to notice a change. So exercise is a great way to be able to identify and share that information with a provider. The key is discussion, open communication, and if there are certain things that are happening, write down the time of day that they're happening, how long it lasts, and share that information with your provider, because we can't possibly make adjustments in medications without that information, and that has to come from you because you're the one living with it. So I really just say that communication is really the key, and a little bit of documentation so that there's accuracy.
Well, perfect. I appreciate it, Dacy. I really appreciate you taking the time today to talk about this, really providing some great information on dealing with the fluctuations within Parkinson's disease. I think you've given us a lot of information we can use and take forward. I'm going to wrap up by saying, I'm just glad you're checking in with WPA regularly. We are frequently updating our website and Facebook pages with exercise, educational videos such as this one, and a number of other resources for you to take control of your Parkinson's disease during your journey. You can also email us at mail@wiparkinson.org with future topics or speakers you'd like to see us cover in the future. Now, hopefully you're finding these educational video series beneficial. WPA relies on donations from individuals just like yourself. So please consider a gift today at wiparkinson.org to continue to keep all WPA programs and services free now and into the future. Once again, I'd like to thank Dacy for being our guest today. Thank you for joining us. Please take care and be well.